Hi guys, welcome back to another episode of Too Many Cooks with me, Charles Burns, and today I am delighted to bring to you an interview with Professor Fox, who I've known through various ventures for some time now, but never really had a chance to sit down and talk about him and what in the work that he does. But it's from what I've heard already, it's super interesting, and hope you'll find it interesting too. So, Professor Fox, or Adam, as we'll call him from now on, welcome to the show.
Delighted to be here.
So, as usual, I like to kind of start how you got into this. I mean, clearly you are, people that don't know, you're a consultant pediatric allergist amongst other accolades, but that's your main kind of focus, right, within the allergy kind of community.
That's my day job. Yeah.
Yeah. So, were you one of those people in school, when I talk about school, like kind of secondary school, that was always into sciences and medicine and stuff, and always wanted to go into the doctorate route, or was it like families, or how did you get into that kind of route?
I've been thinking about this a lot recently, actually, because my kids are now at an age where they're also considering their career options, and my youngest is 16. She's just done her GCSEs and having the rounds of careers talks at evenings, and trying to remember back to where I was at that point. I had a number of friends at school who always wanted to be doctors. I had one friend who I was actually at nursery with, and he used to dissect his teddy bears and operate on them and take the stuffing out and put it back in again and sew them up. And he is now an orthopedic surgeon. There are a couple of guys. In fact, a reminder, I recently remembered this because I got a referral from an ENT surgeon I think he's in Gloucester now, but it was one of those names. It's like, oh, wow, I've not heard from him for a long time. So another kid I was at school with, and I can actually remember when, I don't know whether people do this still now at school, but we had to dissect rats, probably third or fourth year biology, quite gruesome. And you had to sort of, cut them open and then sort of pin them out on a board and display their organs. And at the end of our class, the teacher said, there are two boys that have done such an exceptional job that we all had to sort of go round the class and walk past these two dissected rats to look at them, because they were literally works of art. And again, both of those kids, one of them is this ENT surgeon, another one is, again, a different surgeon. So there are some people who clearly have this vocation that you hear about. I can recall as a 16-year-old having the school careers evening, and they had different rooms for different things. And I remember walking around with my mum, and she said, oh, why don't you go and have a look in the room where they're talking about medicine, that might be interesting. And me saying, no, I'm not really interested in that, and going off to the marketing room and something else. Somewhere between that point at 16 and applying a year later, I made a decision to go to medical school. And I'll be honest, I'm not really sure what it was informed by. But it certainly obviously had a profound influence in what I ended up doing. And I think medicine is one of these careers that once you're on the beginning of the that sort of slope, it's quite hard to get off it unless you make a conscious decision to. So the path of least resistance once you're on it is to just stay on and finish your preclinical degree, go on to clinical school, then apply for house jobs, then start looking for a rotation to train in a specialty. And I had a number of sort of friends and peers who went off and did different things. And in fact, if I look back at the kids I was at school with who did medicine, very few of them are now certainly within the NHS. Most of them are still in medicine of some sort, but they're either in industry or they're just exclusively private, or they've gone overseas. So there's 100 different angles you can go off on, but I sort of stayed and did the very traditional NHS route and went through my house jobs and then decided I wanted to be a paediatrician, and that was very much informed by one of the house jobs that I did with kids. I just loved it. I just enjoyed. It was just so much more pleasurable dealing with children and the parents as well, I guess, than it was with the people when it was the adults with their own issues. And then once I started in paediatrics, most people become general paediatricians. I was quite interested in the idea of being more of a subspecialist, and I was very lucky. I got a very broad range of experience in different paediatric specialties. And what really appealed about allergy was a number of things. The first was it was a small specialty, which meant that although it's quite academic and you were likely to have to do a higher degree to progress, it was one where you could very quickly get to know everybody, get involved in a whole range of different things rather than just sort of have to manage your own local service at your own hospital. There was an opportunity to get involved in research. There was an opportunity to get involved in working with sort of different organisations, different charities and things, opportunity to go overseas to do things, just because there was only a very small number of paediatric allergists, so there's only so many people who would get those opportunities, and so that appealed, certainly for me at the very beginning of my career. I liked the fact that you could really help the patients that you saw. They were often, and this is going back 17, 18 years ago when I first started my training in paediatric allergy, they were getting a really bad deal. People that had multi-system allergic disease, so had problems with food allergies and asthma and eczema and hay fever and a whole range of other things. They didn't really have many experts to see. They were bounced around different clinics. When I was doing my training, I remember at one of the London teaching hospitals, I would often find myself seeing the same kids when I helped in the dermatology clinic, and then helped in the respiratory clinic, and then helped in the ENT clinic and the gastro clinic. You keep seeing the same kids, and nobody was joining their care up. But when you did that, it was so much more efficient and effective. And that's where allergy comes in as a specialty. And I like the fact that it was in its early days as a specialty, and there were clearly going to be some big changes and advances coming up, and that's exactly what's happened. It's been a real privilege being able to be part of a specialty that's truly evolved. And we're having some sort of, really big moments as landmark studies come out, the way that we practice changes, and it really keeps everything so much more interesting and so much more fulfilling as a doctor to be able to help patients in more and more ways.
So you alluded to there where allergy was to where it is, and I guess the next thing is where is it going? So where was it and where is it? And then I guess the follow-on question is, what are the kind of future innovations that you see in this space that will make the kind of care and the kind of long-term health of allergy sufferers and the like lives better?
I think the bulk of what we do is around food allergy. So food allergy never really fitted into anyone else's box. The thing about UK medicine is it's very sort of specialty driven. So if you've got a condition, you've just got to hope that it fits very neatly into one specialty's box. So if you've got congestive heart failure, it clearly belongs to the cardiologists. If you've got severe asthma, it clearly belongs to respiratory people. But if you had food allergy, it sort of didn't really fit with anybody, and there weren't enough allergists, there's still not enough allergists to say that it fits with allergy, because if you only see allergy specialists, you're going to be waiting a long time basically for most people. But from a specialist perspective, where we get to see the more severe cases, it's food allergy that very much provides the bulk of our practice. And sorry, I'm in a side room. It's
okay.
It's all right. I hope it's that your phone, go and grab it. Yeah. All right. Yeah, so it's severe food allergy that makes up the bulk of the practice, and we've really seen I guess best described as a paradigm shift. So if you go back to 2003, 2004, when I started my training, I think who can accurately describe management of food allergy as a very passive process. So essentially what we're offering as allergists was a diagnostic service. You'd come to us and tell us what had been going on, and what we'd do is we'd try to make a very accurate diagnosis. But once we were able to tell you what you were allergic to, essentially all we could then suggest is that you carefully avoided it, and we'd train you on managing or looking at food labels. We'd get the dietitians involved to make sure that if you're avoiding a range of important nutritional foods like milk in small children, for example, that there was appropriate alternatives. We'd train you how to manage an allergic reaction, or recognize an allergic reaction, and know how to manage it. And then essentially we'd all just cross our fingers, see you a few years down the line and hope that it had gone away, which isn't ideal. I mean, that's not how you want to be managing things. But what we've seen change over the course of the next few years is what we often describe as a move to active management of food allergy. And this has got a number of different sort of threads to it. But I think the two key ones will be, first, a much better understanding of the underlying processes that lead to food allergy developing in the first place, and as a consequence being able to influence them to reduce the likelihood of getting food allergy before it happens. And the second is how we manage food allergy if you do get it, and rather than just carefully avoiding it, instead looking at different strategies that can help it either go away sooner, or if you can't make it go away completely, can you make it somehow safer by making that patient less sensitive? And over the last few years, we've very much been in the midst of this sort of transformation from being passive to active in the way that we manage it. It means that now we spend a lot of our time thinking about food desensitization, which is a process by which we can make you less sensitive to the food that you're allergic to. But what it also means is that we've transitioned from what was essentially a diagnostic service to become a therapeutic service, which of course is exactly what we would aspire to do as a specialty. Start being able to say, we can't only tell you what's wrong with you, we can actually do something about it. But of course, it doesn't happen overnight. It's a process. We're definitely on a path now that there's no coming back from. You know, we're not going back to where we were. The way that things are starting to go, clearly the way the wind is blowing, and the specialty is going to be different for good from now on, but we're still very much in the midst of that process. So we can, for example, if you've got those common food allergies, milk and egg, now there's strategies to help make you less sensitive by deliberately introducing it in a different form into your diet, or actually trying to push you more quickly towards outgrowing it by gradually introducing the food into your diet. Whereas with things like peanut allergy, which unfortunately we're not able to make go away, but we are able to help treat them by making them less, making the patient less sensitive to peanuts by this process of desensitization. And then alongside, you mentioned about, where's the future going? I mean, not only has this got a long way to go, but desensitization by different routes is really exciting. So the idea of putting a patch of peanuts on your skin, and as a consequence of that, becoming less sensitive. But then also the use of a whole new class of medications, so something called biologics or monoclonal antibodies, which have very much revolutionized a range of other specialties where they're now used to treat things like inflammatory bowel disease and rheumatoid arthritis, and things where previously your only options were steroids and immunosuppressant drugs, which have got quite nasty side effects, instead having much more targeted immunological treatments that actually get to the underlying root of the problem as a way of helping it, and as a consequence have far less in the way of side effects. We're starting to see an increased use of those in allergy as well. So really, really exciting. And so we've now got a pretty clear sense of what the specialty looks like for the next few years, and what these advances are going to mean. And it's going to be a big job in making sure that we're able to make the changes that we need to ensure that we can deliver these changes quickly and effectively and safely to our patients as soon as possible, because it's always a little bit easier. And unfortunately, I think the NHS environment is quite well suited to this, to just sort of not respond to change, just allow things to just carry on as they are, because it's sort of easier than doing anything about it. We have to really make sure that there's no complacency, that we absolutely sort of don't do a disservice to our patients, and make sure we keep on top of all of these advances and bring them in as soon as we're able to.
That makes sense. You touched on a few points there, one of which I think often people find interesting to understand is, and maybe from what I've read, there isn't necessarily an answer to this. Maybe you can help me with this. But like, why do certain people develop food allergies and others don't? Is there any definitive answers as to why, or is it just kind of luck of the draw, really?
There is probably an element of luck in there, but there's also a significant element of genetics and environment as well. I think there's certain people who are never going to be allergic to things because they just don't have the genetic predisposition in the first place. But there's a large swathe of the population who are what we would describe as atopic. They've got an immune system that does have a skew towards allergy, but whether those allergies actually manifest themselves and happen will depend on their environment. So it's not just, you're not born with allergies, you are born with an allergic predisposition, which is inherited. And you can predict from whether one or both parents have got that predisposition themselves, how likely you are to have it. But then it's a whole series of things that might happen afterwards. And certainly what we see very commonly in children who have got that allergic predisposition is what we call the allergic march. And this is this progression of allergic conditions that we see. So classically, the first one is eczema, which will manifest itself often in the first few months of life. Now, eczema is genetically programmed. It's not an allergic condition as such itself, but if you have underlying eczema, particularly in early infancy, it very much predisposes you to get allergies in the first place. So it's kids with eczema who are the most likely to be the ones who go on to get allergies to milk and egg and peanut and sesame and tree nuts and things like that. In fact, they're the same kids who, as they get older, are most likely to go on to get things like respiratory allergies, so asthma, allergic rhinitis, hay fever, things like that. So having that predisposition can set you on that path, and then the environment seems to influence how much of those problems you get along the path that you go.
And then leading on from that, how do, and most of the point, why do like children kind of grow out of allergies? Some do, some don't. How does that kind of happen, growing out of these things?
So it's actually a really, really a big question that we don't really have in my mind, a helpful answer to, because we know from observation that if you've got a milk or an egg allergy, you're very likely to outgrow it. We know similarly from observation that if you're allergic to peanuts or tree nuts or fish or shellfish, that you're really unlikely to outgrow it as you get older. Why? I don't think we have a good answer to that. Some people suggest that, well, there's a lot more milk and egg just in the environment generally. So maybe there's a degree of low level exposure that happens to everybody just because there's such ubiquitous allergens everywhere that somehow we're desensitized. But I don't think that really explains it in a helpful way. There's plenty of people who have chronic ongoing exposure to other things that they're allergic to. We don't see that happening. And it's so consistent that people outgrow their milk and egg allergy, and so consistent that people don't outgrow other allergens, that there's got to be something about the nature of the allergen that makes you more or less likely to outgrow it. So I think it's one of the many areas that we've got so much more to learn. We don't, for example, I think this is an absolutely fundamental question, really understand why one child who has a history of eczema and has a measurable level of allergic antibody against a specific food can eat that food and nothing happens, where another child can have a very similar amount of allergic antibody against the same food, but they have anaphylaxis when they eat that food. What is it about, the difference between these two kids who superficially appear to have very much the same issue, yet their immune response is so profoundly different? Well, I think it simply reflects our lack of understanding of the nuance and complexity of the immune system and the way that it responds to things. We've got an enormous way to go. We're absolutely in the infancy of our understanding of these things.
You mentioned there again, this is most people in the community will understand this, obviously, but the amount of people watching / listening that aren't familiar with this kind of with food allergy as a whole. So what is anaphylaxis and what's actually happening? I suppose it's kind of the same question. What's happening to someone that has a food allergy to, say, peanuts, for someone that's just digesting them normally?
So maybe we step back a little bit more than that. So, what's the difference between an allergic response and a normal response to anything? I think the essence of what allergy is that it's an inappropriate response by your immune system to something that's harmless. So whether it's pollen getting up your nose, peanut that you're eating, or a cat that you're stroking, all of those things are made up of proteins, some of which are shed or you come into contact with, whether it's the pollen grain going up your nose or the dander or the saliva of the cat that you're stroking or the protein in the food that you're eating. And our immune system is designed to recognize proteins. And what it's supposed to do to those things, which are harmless, is ignore them. And when your immune system sees something but decides to ignore it, we call that tolerance. And that's what we would expect you to do to all these harmless things, as opposed to proteins that are part of bacteria or other potentially dangerous things that you would want your immune system to notice and actually respond to, but respond to in a way that ideally destroys them because they're something dangerous. Sometimes it slightly irritates me sometimes because often allergy is described as when your immune system gets a bit confused and responds to something harmless as though it's dangerous, which implies that the way that you respond to a peanut allergen or a bit of peanut protein is the same as you would respond to a bacteria, but that's not the case at all. Actually, if you look at what the origin of the word allergy is, it comes from allergos. It means, in Greek, it means other, i.e. there is a third distinct response that isn't tolerance and just ignoring something. It's not responding to it because it's dangerous and an infection and trying to kill it, but actually it's another response. But it's another response that is not helpful, doesn't serve a useful purpose, and if it's an over-enthusiastic response, can actually cause harm to the host, so to the person whose immune system is responding. And that's where allergy fits in. So essentially it's an inappropriate immune response that can potentially cause harm. And what's happening, and so I guess the best example is peanut allergy. We know the most about it, but it's no different if this was responding to a pollen grain or cat dander. But when your immune system has made a bad decision that you're going to be allergic to peanuts, what happens is your immune system produces what's called immunoglobulin E, the allergic antibody, produces this stuff in the immune system. They're like little areoles So if you imagine they're just out there looking for stuff to see what's going on in the outside world, and they stick to the surface of something called mast cells, which are cells in your immune system. You've got them in your skin, and you've got them in your airways, and you've got them, circulating, similar things circulating in your blood. And what they do is they keep an eye out to see whether you come across that thing again, i.e. peanut protein. And if you were to eat another peanut, what will happen is the little immunoglobulin molecules will pick up the fact that you've eaten it, they'll notice it, or stick to it, and that leads the antibody to send a signal into these mast cells that they're stuck on the surface of, and tell them to release their histamine. And the histamine is this chemical that's kept in little packets inside the cell, along with a whole range of other very similar chemicals. And if the cell is triggered to release the histamine, you then get the effects of histamine being released. And histamine is a very potent chemical that can cause itchiness and hives and swelling, which is typically what you see. It's no difference if you get stung with a stinging nettle, that's got histamine at the end of it. So it's the same things. You get what we call the wheel of a flare. So the sort of the bump of the itchiness and the swelling. But if you get larger amounts of histamine released, they can have more profound and potentially dangerous effects. And that's when you get into the territory of what we call anaphylaxis, which is essentially just a severe enough reaction to be potentially life-threatening. And that's when it affects either your breathing or your circulatory system. And the way that it will do that is histamine will cause your airways to narrow, which is obviously a bad thing because they need to be open to get air in, or it will cause your blood pressure to drop. And the way it does that is it causes blood vessels to just relax. And so there's less pressure in your system. And if your blood pressure drops too much, then you can't, you've got enough, not got enough force from your heart to pump the blood around your vital organs like your brain. And then you start getting dizzy and lightheaded and confused and can potentially collapse. So this histamine stuff gets released in variable amounts. Usually it's a little bit and you get a mild reaction, but if you're unlucky, you can get this anaphylaxis. And in thankfully rare cases, it can be fatal. And about, in the UK, 10 to 15 people a year will die of anaphylaxis to things like food or medications, insect stings, latex medications, a whole range of different things that might cause it.
Is, I mean, you're obviously very close to this, but it seems from just as a, forgetting what I do as a kind of entrepreneurial job, but just as a layperson, that certainly intolerances and it seems like allergies are becoming more prevalent in society. Is that true, or is it more that people are just more aware of it now? Like which of those is more true?
Yeah, I think it depends on your time scale. If you sort of say, I mean, look, if you go back to the origins of hay fever, so in early 19th century, I think 1819, there was a paediatrician in Manchester called Jonathan Bostock, and he had hay fever, and he related, he was sort of able to connect the fact that his symptoms coincided every year with the pollen seasons. And he decided he was going to publish this in the Lancet, but like anyone wanting to publish something, he wanted to get a case series. He was pretty sure he wasn't the only person. It took him years to find more than about 10 or 20 cases, which he then published together. Whereas now, 25% of the adult population have got hay fever. So is there more allergy over the last 200 years? Well, unequivocally, there's been an absolute explosion of it because it's gone from being something that's extremely rare to something that we now know is very common. There was a case report in the early 20th century, 1905, of a child with an egg allergy who his doctor wrote up against the Lancet to talk about how he'd been desensitized by giving him small but increasing amounts of it to make him less sensitive. But it was considered a bit of a curiosity that this kid reacted when he had egg, whereas now it's thought to affect anywhere between sort of 6 and 9% of the paediatric population. So again, massive increase, but over a long period of time. Whereas if you ask, well, is there more food allergy now than there was 10 or 20 years ago? Well, actually, the evidence is that there probably isn't. So I think we've got a combination of a sort of a longer period of time where there's been a marked increase in all allergic disease, but that's over decades. And then more recently, a much greater awareness and understanding of these things, a much better diagnosis. And so as a consequence, there appears to be more of it around, but there's no compelling evidence that we're in the middle of this sort of continuing upward curve of lots more asthma and eczema and hay fever and food allergy. What interestingly has pretty unequivocally increased over the last decade or so is the number of children pitching up to A&E with severe allergic reactions. Now, is part of that because when you have a more severe allergic reaction, you recognize it for what it is and are more likely to show up at the hospital because you realize it might be dangerous, even though in the overwhelming majority of cases it turns out not to be. Or is there just a worsening of the severity of the allergies that we have out there, but no evidence of there being more allergies than there were? We don't really know. And this is something that's been reproduced in the UK, in the US, and around Europe, in Australia, elsewhere. There do seem to be more people pitching up to A&E with severe allergic reactions.
Talking of kind of globally, do you find that in different cultures and in different like geolocations, etc., that you have different food allergies more prevalent depending on the diets? In other words, are diets a big part of why people have and have not got food allergies, or is that not so relevant?
No, it's really relevant. And there are certain foods that are eaten pretty universally that are very allergenic. So I think there's some foods that are just by their nature allergenic. It's usually because it's something about the way that we're exposed to them. There's something about the nature of the structure of the protein that just makes some things more likely to cause allergies. And some of them are things that are in the diet pretty universally. So milk and egg, those are usually the top two allergies in pretty much any country you go to. But once you go beyond that, then it becomes very different depending on where you are. So for example, in India, it's much more common to be allergic to chickpea. In the Middle East, it's much more common to be allergic to sesame, a lot of hummus being eaten there. In Scandinavia, fish allergy is more common. In the US, UK, Australia, there's a lot more peanut allergy. There's other nut allergies in other parts of the world. So very much influenced by what's being eaten. And you don't even just see that on a country level, you see that on a much more of a microcosm of that. If you come to any London allergy clinic, of course, we have very, very diverse populations. And so predictably, within British Asian families, for example, it's much more common to see allergy to cashew and pistachio than it is to see allergy to peanut, which you see more commonly in Caucasian families, whereas there's certain Bengali fish that you only see allergy to in the Bengali community. There's certain things that I see more commonly in the Jewish community. There's certain fish that are more likely to cause allergy, for example, in the Black Caribbean families, where it's more common to be allergic to things like bream and snapper. So essentially reflecting the family's diet. So you see it even within your own clinic, because of course that just reflects what's being eaten at home. And then if you start thinking about, well, why do kids become allergic to certain foods? It makes sense, because our understanding is that if you get the child with eczema, and bear in mind eczema is the major risk factor here for having it, and the worse your eczema is and the earlier your eczema starts, the more likely you are to have a food allergy. What's happening is, or at least our understanding of what's happening, is that other people in the household are eating certain foods, they're then kissing and touching the baby who has eczema. So the immune system, through the angry skin barrier that's excoriated, because that's what eczema is, the skin barrier is all leaky. The immune system underneath the skin is able to see the food that's been touched onto it in a way that's not really designed to, because if you didn't have eczema, the skin barrier would be a solid barrier that would prevent that from happening. And your immune system in your skin sees these different proteins, peanut protein, for example. If the baby's never eaten peanut before, which of course before they've had solids introduced, they're not going to have done, it won't recognize that protein as being food, because the gut immune system, which would normally be the part of the immune system that decides whether something is food or not, hasn't seen it yet. So it gets the opportunity to make a bad decision and suggest that you should become allergic to it. And certainly what we found in research that we've done is that if you've got a child who's got significant eczema in the infancy, who isn't eating peanut themselves, then the more other people in the household that are eating peanut butter in particular because it's sticky, and then kissing and touching the baby, that seems to be the stimulus for that child to be at particular risk of getting a peanut allergy. So that as they get a little bit older, they get 6-7 months and they eat it for the first time, they react to it the first time. And that's because they've already become sensitized through the skin. Now that took a lot of sort of working out, because there was always a suspicion that this sensitization, this sort of priming of the immune system against the food, which must have been happening because kids are reacting the first time they eat peanuts, was happening because of passage of antibodies in utero while the mum's pregnant or when the mum's breastfeeding. But we've now got really good data to show that's not what's happening. It's actually happening after the child is born. The child isn't born with the food allergy. They've got eczema. They then have contact through the skin with these allergens, and it's that exposure which then leads to what we call sensitization, so that they become allergic that way.
So in terms of managing someone that's got any kind of food allergy, it's called, the people that aren't in the community, like lay people, will have heard the term Epipens. What are they? What do they do? How do they help the situation?
So Most allergic reactions are relatively mild. They cause itchiness and swelling, and they're uncomfortable, but some antihistamine and things look much better 10, 20 minutes later. But if you're unlucky enough to have a more significant reaction, which is potentially life-threatening, so an anaphylaxis, then antihistamines just won't make any difference whatsoever. It's gone beyond that. And the only medicine that will really make a difference is adrenaline. So for people that we consider to be at high risk of having an anaphylaxis, a more severe allergic reaction, so typically those people who have got food allergy, but also have a history of having severe reactions, or they also have asthma, which is a major risk factor for severe reactions, they're advised to carry adrenaline because adrenaline works best the earlier it's given. So waiting, 10, 15 minutes for an ambulance to show up, you may miss that window of opportunity to resolve your allergy before it's gone too far. So by carrying these adrenaline pens with you and having them in a form that's easy to give, then it means that out in the community, you can have a reaction. And then moments later, if your reaction is looking severe, you can get on and give the definitive treatment that will make you better. So there's been an absolute explosion in the carriage of these. So anecdotally, in the 1980s, there were no more than 80 or 100 people carrying adrenaline pens, and now they're sitting in the order of 370,000 people carrying them. And there's no suggestion that we've seen, a commensurate increase in allergy. What's happened is that as there's more awareness of anaphylaxis, people are going way beyond the scope of the guidelines, which suggest that you only carry adrenaline if you have certain risk factors. And instead, what's often happening is people with any food allergy at all, even though the risk is extraordinarily remote, are all carrying EpiPens. And that's not helpful for two reasons. Firstly, it creates an enormous amount of anxiety amongst people who are behaving as though they're at risk of some life-threatening event happening at any moment, when actually the risk is beyond minuscule in their case. But also it's unhelpful because it distracts from the smaller community of people who really are at high risk and should have real focus on their care. And that sort of gets diluted out, certainly at primary care level, because you can't differentiate them from the people who are at a much, much lower risk. So it's a difficult area because severity of reactions is unpredictable. So you can't say to anybody, you definitely won't have a bad reaction. You definitely don't need an EpiPen. And there's a little bit of a knee-jerk response. If you're saying, well, we can't rule it out, so you better be equipped for all scenarios. Every time you get in the car, you can't be sure you're not going to be in a car accident, but you don't wear a crash helmet every time. So it's trying to get that balance right of making sure that the people who are at generally increased risk, where that risk has gone past the threshold that actually, this really might happen, let's make sure we're well prepared for it, versus people carrying them just because it's a remote possibility. There's always a dangerous temptation to say, oh, well, the only reason you're against that concept is because of the money. You don't want to spend money on patients with people with allergies because you're worried about, rationing healthcare and somebody else missing out. It's not that at all. But blanket prescribing of EpiPens isn't helpful because it just makes lots more people feel very anxious about something that's profoundly unlikely to happen. So getting it right here is a little bit of an art, and there's a science and an art to it. And certainly in my practice, it's a long discussion about whether it's appropriate to carry adrenaline or not, because it really does have a big impact on people's day-to-day lives. Not just, especially I think maybe more so for kids, because, every time you go for a play date, every time you go to school, every time you go anywhere, everybody has to know how to use this, use these pens. And there's always that sense that you're handing somebody over and saying, here's this ticking time bomb who will die if you eat, if you give them the wrong thing to eat, when that's a gross misrepresentation of the reality of their allergies. Now, of course, there's a small number where that is a reasonable representation. Of course, they should be carrying these things, but I'd much rather that we stuck to those who are at high risk rather than just blanketly gave them out to everybody, which is a little bit of what's happening at the moment.
And so what does the adrenaline actually do to fight against the anaphylaxis attack?
So if you remember, the two sort of key components of having an anaphylaxis were the tightening up of your airway and the widening and sort of reduced blood pressure because of the widening of your blood vessels. What adrenaline does is directly oppose both of those things. It tightens up your blood vessels and keeps your blood pressure up, and it forces your airways open so that you can breathe more easily. So it sort of directly opposes, whilst and so and you get a period of time that it works, and usually by the time it's worn off, there's a reasonable expectation that that the effects of the anaphylaxis have worn off as well. But if they haven't, you just give more adrenaline until it has.
So if you're a parent or you're someone else that that's watching, listening, that's kind of thinks, oh, I might feel like, when I eat certain foods, I don't feel so good, or whatever the case may be, what should someone do in that instance? How do they kind of check out if they have an allergy or they should be avoiding certain foods? How would they go about that?
bear in mind there's a whole breadth of things that can happen that will make you feel not well after you've eaten something. We can very broadly divide it into two types of reactions, what we call toxic reactions. So those are reactions where whoever it was that ate that food, they're not going to be well. So for example, if you've left a chicken sandwich in the fridge for a week and it's not in a good place, whoever eats it, they're going to get food poisoning type reactions. And then there's a different type of reaction, is what we call non-toxic reactions. So those are ones where one individual can eat it and they'll be absolutely fine, whereas another individual can eat it and there'll be a problem with it. And that might be because of something to do with your immune system, in which case we call it allergy. So food allergies are immune-mediated sensitivities to food. Or it might be because of a different effect where your immune system isn't involved, and we'd refer to that as a food intolerance. So food intolerances might be things like some foods actually contain essentially drugs that have a pharmacological effect. So coffee contains caffeine. And if I have more than a cup of coffee, I'm absolutely up on the ceiling with a heart rate through the roof because my threshold to tolerate it's really rubbish. Whereas other people can drink a cup of coffee and have no effect whatsoever, and they're absolutely fine. So that would be a good example of an intolerance type reaction, a pharmacological intolerance. You can get enzymatic intolerances. So those are the ones where you don't have the enzyme to break down that particular food. So the classic one here, really common one, is lactose intolerance. Mm-hmm. So loads of people, particularly people who come from ethnicities, basically non-Caucasian ethnicity, they usually are fine breaking down lactose when they're children, because there's lactose in breast milk, so they need to be able to do that. But they lose the ability to do that over time, because why wouldn't you? It's sort of this bizarre idiosyncrasy of Northern Europeans that we've taken to drinking the milk of other animals as part of our diet. The reason that Northern Europeans can do that is they actually have a genetic mutation that means that instead of the amount of lactase, which is the enzyme that breaks lactose down, lining the wall of their guts, instead of it slowly disappearing over the first or second decade of their lives, they continue to produce it. So that means as an adult, a Northern European typically, or most of them, can drink the milk of a cow or a horse or a sheep or anything else and not suffer any ill effects because they're able to break down the lactose sugar that's in there. Whereas if you're Chinese, for example, or you're one of the sort of 5% of Northern Europeans who don't have that genetic mutation, then by the time you're 15 or 20 years of age, you won't be able to break down the lactose. You'll be lactose intolerant. And as a consequence, if you drink something or eat something with lots of lactose in it, you'll get a very, very upset tummy. You'll get very bad wind. You'll get diarrhea, and all of this because you're not able to break the sugar down. The sugar gets further down into your gut. It stimulates bacteria that produce lots of gas as a consequence of being exposed to all that sugar, which is essentially food for them, and you get all the symptoms of that. So nothing to do with your immune system at all. And it can cause unpleasant symptoms, but it's not going to kill you. So that's a good example of another sort of food intolerance. And then you get the slightly bizarre ones that are difficult to explain. Certain people just get certain things when they eat certain foods, but reproducibly, so it's real. But the only way you can sort of work it out is, do the symptoms stop when you cut it out, and do they return when you reintroduce that same food? But none of those involve the immune system. Whereas once the immune system's involved, then it's allergic. And in the case of most food allergies, there's the potential for them to be quite potentially nasty. So that's those are the important sort of differences between the two. If you're not really sure, you need to go and see your GP. There's actually a very nice guideline. There's a national guideline about diagnosis and assessment for food allergy in childhood. Not so helpful for the adults, but it's what's called a NICE guideline, National Institute for Clinical Excellence. And that very much sort of breaks down sort of the questions your GP should be asking you, the tests that are useful depending on the circumstance, that should get you to a diagnosis of having a food allergy or not a food allergy.
I think I have two questions, one which might be a bit more controversial, possibly not your remit, but one that I think certainly is, which is the final one being, or penultimate question being, someone that's got a food allergy or intolerance and say they've gone through, see someone like yourself, and that's the case, they carry their EpiPen. What should they be, when they're going out to eat, because that is what obviously lots of people like to do in restaurants, what should they be doing? What's kind of good practice for someone that's either got an allergy or intolerance or think they have?
So I sort of think about it in three ways. There's things that they should be doing before they go, things they should be doing when they go, and things they should do if there's a problem. The The first is make sure you've got a proper diagnosis. Make sure that you really do know everything that you are allergic to, so that you're not finding out the hard way. We know there's certain things that go together. If you're allergic to egg as a child, you've got a 20% chance of being allergic to peanuts. If you're allergic to peanuts, you've got a 40% chance that you'll be allergic to another nut, 25% chance you'll be allergic to sesame, a 4% chance you'll be allergic to lupin. You need to have this out with your doctor to make sure you have a proper full diagnosis. And then also with your doctor, have done a risk assessment as to sort of, what are we worrying about here? Is this an intolerance type thing, which we need to be careful to avoid, but nothing terrible is going to happen if you accidentally have it. It'll be unpleasant, but you'll get over it. Or is there a risk of an immediate allergic reaction, in which case you need to have the education to know how to recognize that and how to manage it if it happens, and make sure that you're carrying those medicines with you so that if you need them, you've got them. And then when you're there, it's all about knowing how to understand food labelings, knowing about what the obligations are. So for example, in a restaurant, you can't apply the same rules as if you were buying a can of beans in the supermarket, because the laws are different about what they have to say and how they have to display it. Now, things thankfully have improved more recently because of you may have heard of Natasha's law, because of the tragic death of this young lady with sesame allergy, who in good faith ate a sandwich from Pret that didn't highlight the fact that there was sesame on the side of it, made the incorrect assumption that they were meant that that they had an obligation to do so, and if it wasn't there wasn't sesame in it. And it turned out there was lots of sesame in it, and actually Pret hadn't broken the law. Their obligation was, if they're selling what's called pre-packed for direct sale food, i.e. stuff that's made on the premises there and then sold straight on, even though it's put in a cardboard container, they don't have obligation to list the allergens on the side as you do if it was something that was sold in a supermarket. Instead, they had an obligation to say, if you've got food allergies, ask at the desk, and we've got a book, or we need to tell you what's in it, and so you'll know what not to eat. So that's now changed. They do have to display on it for pre-packed for direct sale. But when you're in a restaurant, again, that's different, and their obligations on the menu are not completely clear. You do need to be asking specifically about what you're eating and highlighting, sometimes not just to the waiter, especially if you don't feel they've got the message. Sometimes you need to speak to the manager or even the chef to say, look, this is what I cannot eat. Is there a risk here? Is this sensible, etc. And make sure that you feel that you can trust them. I'm an advocate of saying, people with allergies should be eating out, but often what they'll do is they'll find the places they feel safe. They'll find places where they know they're being taken a bit more seriously, and that people get it and understand and listen to them, and respond accordingly, because otherwise things can go very horribly wrong. And there's some awful cases where things have gone profoundly wrong, and it's usually just a breakdown in communication. So the awful thing is the patients have gone in there and they've absolutely done the right thing. They've said to the serving staff that they've got a milk allergy, for example, and just somehow that's got lost between the waiter and the chef, and then the food coming back out with tragic consequences. And a lot of that speaks to the need for staff training, understanding in the catering industry, and I think a lot's happened there. And I think credit to the Food Standards Agency, who's been a real force for good in this area, and it is continuing to evolve the legislation. But there's still an element of risk, and so you need to make sure that if you do have an allergic reaction, that you recognise it and respond to it quickly with appropriate medication. And sadly, when you look at the stories, the awful stories at the inquests of when things have gone wrong, there's often things like people didn't have their Epipens with them. They had them, but they didn't use them, or they had them, but they didn't know how to use them. Or they just waited for reasons that sometimes aren't clear before using them, and with tragic consequences. So it's really important to make sure that you know exactly how you're going to respond when things don't work out well.
That makes sense. This one's more of it's more of a personal question, actually. It's something that I've kind of I've worked for a good period of time, maybe 6 months ago. I kind of decided I'm going to go down the whole vegan diet and just kind of see how that lies. And I've heard, again, it might not be necessarily your area, but just because you're in the food space, you might have an opinion, maybe from an opinion in scientific. Are you missing lots of kind of nutrients that you need by going down some of these more specialized diets that are kind of vegan, I suppose, is the best one to kind of use an example, versus maybe a more of the average diet that we've been accustomed to, the past years?
I think probably not, but there was a risk. So, my advice, if you're going down that sort of route, is if you're able to have a chat with a dietitian, or make contact online and get proper advice on this, then that's a good idea. Obviously, with food allergies, people have these exclusions foisted on them. You know, they can have a sometimes completely random selection and sometimes a large selection of foods they just can't have. And we will always, I mean, it's sort of an obligation really in a specialist allergy clinic to make sure that they get sat in front of a dietitian to really go through what the consequences nutritionally are of them not being able to eat things like milk. Making sure that there was an alternate source of calcium, because you're going to have to get it from somewhere. Whereas if you're allergic to egg, you're not really missing anything. There's no sort of nutritional consequence of that. But with a number of other things there is, and especially if, you know, and of course, Sod's law, it's typically foods that are common in the family home are the things that cause allergies, then it can really make things very difficult. So it's really important to sort of be aware of the risk of nutritional shortcomings when you're on a restriction diet, whether it's for ethical reasons or social reasons or medical reasons, and make sure that that doesn't happen.
Great. I think that's a good place to lead the conversation. It's been super interesting, and I'm sure people both that are within the community and those that are not within the community will get a better sense of the overall kind of picture of what's going on, and kind of some good actual practical advice there as well, Adam. So really thank you for your time, and speak to you again soon.
Thank you.